Hello, and welcome to a tutorial for Noxious thermal sensory testing. This test is done to determine whether or not a patient displays clinical symptoms of altered pain and sensation. You may have seen these patients walking into your clinic with a type of pain different from usual muscle soreness, like a burning sensation. They may also describe pins and needles or numbness along dermatomal patterns. There are many clinical uses of identifying sensory changes, including early diagnosis of sensory neuropathies, assessing the extent of sensory dysfunction, developing appropriate treatment plans, monitoring the clinical course of sensory abnormalities, assessing response to therapy, identifying potential responders to neuropathic pain treatments, predicting outcomes, so identifying those at risk of developing persistent pain, and sensory phenotyping, differentiating patient subgroups. Different sensory fiber types detect different aspects of pain. A-beta fibers carry information related to aspects of touch. A-delta fibers carry information related to mechanical and thermal stimuli. C fibers carry information related to mechanical, thermal, and chemical stimuli. Patients may experience increased, decreased, or no pain responses to a stimulus that would normally be painful. They may also experience increased, decreased, or abnormal sensation, which is usually determined by touch. Different tests evaluate the response of different fiber types in our patients. Today, we will be focusing on the Noxious thermal sensation test.
Alright, so we're going to be doing a sensory test on Jono over here. It's going to be a cold sensory test. So Jono, you've been telling me that you've had left elbow pain for a little while, and you've been feeling the numbness and the pins and needles down your arm?
Yes.
Yep. So we're going to do something called a cold sensory test to see how your arm reacts to it. Basically, I have here a bucket of ice water, and you're going to put your left arm or put your hand all the way down to the bottom we'll try for about a minute or two. I'll be timing it for you, and whenever the time's up, you can remove your arm. If you can't stand it for some reason, if it's just too much for you to bear, you can take it out. Alright? Are there any questions before we start?
No.
Alright, and your sleeves rolled up and everything? Alright, so just put it in there and time starts now. Alright. And
Oh, that's beginning to hurt really bad.
Yeah?
Yeah.
Okay, yep, take it out. And you can use your hand to right there.
The patient in this video could only last 20 seconds in the immersion cold test instead of the full 60 seconds. This means the patient displays cold hyperalgesia, or a painful response to a normally cold sensation. This result can help with not only the clinical implications as mentioned previously, it can also help with predicting outcomes in patients. In patients with whiplash-associated disorder, cold hyperalgesia has been shown to predict disability and mental health outcomes at 12 months post-injury. In patients with lateral elbow pain, cold hyperalgesia has also been shown to predict the risk of pain and disability. In patients with sciatica, those with impaired cold detection predicted outcomes of epidural steroid injections. As you can see, sensory testing plays an important role throughout the course of a patient's condition, from assessment to prognosis. I hope you found this video useful in educating about cold hyperalgesia and its clinical applications. Thank you for watching!